I just have to ask, how do you know how my immune system was responding between the first and second treatment?
You can actually look at the internal structure.
Hmm.
And when you start looking at the internal structure, you'll see the differences. You'll see, oh, this part of the tumors looks like it's responding. It looks like there's immune cells infiltrating into it. This one is not. This one's actually in the tumor. You'll see this differences in the tumor doing this. And we made discoveries in mutations in P53. I mean, all sorts of things, so it was crazy. The stuff was going nowhere. So, but that's what led. So eventually, it was like we did the work with the P53 adenovirus, and we were injecting the mice, and it was curing the tumors. And so they took that trial, and they're like, they were going to take this into humans. I was like, great. I was like, that's great. I want to see what happens when it goes into humans. I said, this looks like this is going to be amazing. And when they take it to humans, what do? They start giving it intravenously. And I asked the doctor, who was kind of like, he was like way above. I mean, I'm 21 years old, I think, at this time. And he's way above me. I mean, this guy, I don't know who he is. He's like MD, PhD, and but like, he's going to handle a trial. And I said, well, wait a minute. We cured the mice, but we injected it into their tumor. But you guys are going to do the human trial, but you're going to give it intravenous. He said, that's the way we give it. I said, but no. I said, we gave the mice intravenous. It didn't work. It only works when you inject in the tumor. So why are you doing the human trial intravenous? And I said, but that's how we give the drugs intravenously. And I said, you can't inject it in the tumor. And they said, no, it's too difficult in humans to inject in the tumors. And I mean, so I remember this conversation. And I was like, okay, well, look, I'm 21. This guy's like, he's like, I don't know, professor, MD, PhD, high level guy. And who am I to tell him anything? I mean, he obviously knows better than me. He's an oncologist. He's a biochemist. And so I was like, oh, okay, yeah, I guess we can't stick, needles into tumors. In the humans. Then what happens? I finished my work at the lab. I finished, college, and I move on to medical school, and then I go on and I start medical school. And my first year of medical school, I have radiology combined with anatomy, and so I'm going to try to be a doctor. And then this interventional radiologist comes in and says, hey, we use imaging and we stick needles in tumors and we biopsy all of this. He says, wait a minute, so you guys stick needles in tumors? And he's like, yeah, we stick needles in tumors. I was like, so you can inject drugs if you can stick the needle in there, right? You can biopsy it. And the guy's like, I don't know. We don't do that. I was like, well, but if you can get to the tumor, then you can inject drugs. And he's like, yeah, probably we can. And so then that's when I said, wait a minute. At that point, I was planning to be like a MD, PhD. So I was going to do like biochemistry, like molecular biology stuff, and I was going to do, and I was going to be a medical oncologist. That's what I thought I was going to be. I said, wait a minute. I said, these radiologists, these are guys that have the ability to stick needles into tumors, and that's what we do with the mice, and that cures them. So I said, I'm going that way. So I'm like, I'm going to be a radiologist, because that's where the power is. It's not with those guys just giving IVs. That's like nothing. I was like, you got to get to the tumor. And so that changed me. At that point, I was like, okay, I'm going to be a radiologist. And I dove into what was going to be radiology. And that was my main focus. Radiology was a very competitive field to get into. You need to be top 10% of your class. And I did everything I could. And I went around and I then found the people who were doing radiology stuff for cancer, like the interventional stuff for cancer, like the University of Mississippi with Patrick Sewell, and I went and I followed them, and I would get like a special permission from my university to transfer to do like an outside work at that place to be with those people, and that's how I did it, and then ultimately ended up in my residency working with a couple of guys who had developed the first CT guided procedures, and then everything took off from there. So
yeah, no, that's I'm glad that's the path you took.
That's a kind of background story, and it's a pretty interesting story. all the stuff.
Yeah, that's great. And like, I mean, for somebody to tell you that you can you can inject a tumor in a mouse, but you can't in a human that's 100,000 times as big. Like,
yeah, well, and for me, it's like at that point, I mean, I'm nobody. Like, I'm a college student. I'm like a sophomore, junior college student. I mean, I had like special skills I guess they recognized, because it was weird. Like, I went and I started, and I went to like a small university. I was like, it was like a nobody. I mean, we my family didn't have any money. We had to go like wherever I could like get into, as close by, you know, where I could drive to. And it was weird because this university had just built a brand new chemistry department, and they got all this equipment and nobody knew what to do with it. And they're like, that's your lab. And I was like, oh, like brand new. I mean, it was a brand new building, the whole thing. And I opened up, it's like, I've got millions of dollars of equipment in here. I could do everything. I mean, and they're like, they just gave the keys to me. They're like, there you go. Like, this is your lab. And I really couldn't believe it. I mean, I was really like they're just like, yeah, go in there and like figure some stuff out. And that's what I did. I went and like, I remember the machine. They had all these machines. All this stuff we had we had mass spec. We had HPLC. We had all these different stuff. And they're brand new machines. And I asked the professors, I was like, "How do you run these things?" And they're like, "We don't know." And I was like, well, "Where's the instruction booklets?" I mean, which thankfully they had the instruction booklets, right? I mean, like, but like nobody knew how to. My professors didn't know how to run any of the stuff. Yeah, they had no clue. I did. I went. I got the instruction booklet. I read the stuff. I figured it out and ran the things. I'm running and then coming back and like giving them the data on all this stuff, and they're like, what is this doing? And I can't, you know. So when I had this outside program that was with the bigger universities, which was Tulane, LSU, and Ochsner. Ochsner is a big hospital system in New Orleans that does a lot of research. And I mean, they have primate facilities. They have crazy stuff. It's weird, the stuff that they have there. I mean, it's really, you'd be surprised. I mean, this is really like secret type stuff. And I got involved in them with their projects, and got involved like with things that they were doing. And when I got connected into that was just a different experience. And then now I'm connected in with them, and then we have our lab stuff, and then I have their lab stuff, and I have everything in the world. I mean, and we're doing, you know, DNA sequencing and Western blots, and we're doing stuff that, like, you know, was all high tech at that time. And we had like everything. It was amazing. And so we were just like experimenting, coming up with stuff. And so when I got switched over to this project that was actually at the Ochsner Hospital Research Foundation, they'd been working on this gene P53, which is tumor suppressor gene. It was like molecule of the year and all this stuff. And so me my background being in organic chemistry mostly, I said, well, I can look at the DNA structure, and I'll tell you by the bonding strength where the DNA is going to mutate. And I'll tell you what mutations are going to occur, and that's what I did. I analyzed the structure of P53 and looked at the bond strength and predicted the mutations. And then we made a drug that would bind to that to block mutations to treat the cancer early on. That's what we were doing. This is 1994. Yeah. So. And then we were doing this like fast. I mean, it's like this. I mean, I'm talking about like literally we would have the problem, and then we have the solution in a week or two. I mean, in like a week or two, and then we're like in animals. Like we're doing like stuff like right away.
I just wonder why everything takes so long. Like you're treating the treatments that you do now. We're probably 20 to 30 years away from Canada.
Oh yeah, you know. So there, the LSU system was weird because we had like this sort of freedom to do whatever we wanted, and I kind of got this idea like, oh, we can do all this stuff because they allowed us to do it. It's just and then I ended up going to LSU, but to a different part of LSU for medical school because they have two systems. I went to the Shreveport system, which is a different research oriented side, but separate from these guys. And then then ended up in Alabama, South Alabama. But when I got to South Alabama, that was a whole different group. And so I get there and I'm like, hey, I go to lab people, I'm like, let's start making some gene therapies and we'll inject them in the patients. and those people there were like, well, okay, all right, well, that's kind of weird, but maybe we'll do that. And so, but then I convince them, and then like we start doing like this stuff. But then at one point, then the professors were like, hey, like, what the hell are you doing? And I was like, oh, just like we're making the gene therapies for the patients, and they're like, well, who gave you permission to do that? I was like, I don't know, nobody. That's how we started developing the intratumoral stuff. So we were doing ablations, and we were, treating patients, and we're saying, gosh, we can inject things into the tumor, and so the first time that we started doing ablation and injection into tumors, 2002, 2003. But I applied for the patent for the combination of ablation with pharmaceutical injections in 2004, which is online. We abandoned it because I didn't have enough money to put it through. The university, the situation, I applied for these patents, and the university said, hey, wait, all the patents you applied for, you don't own, we own everything you do. So, and I was like, well, but you guys aren't giving me the money to pay the lawyers for the patent. So like, it's like wasting my time. So I just said, forget it. But you can look it up. Actually, it's like, I'll show you. So
they might be wishing they had that patent.
Yeah, it would have been a good patent to have. I tried to tell people, like, I think this patent would be worth like a lot of money, but yeah. So you can see it's and so and then you see, you look at the application date, 2004, right?
That's great.
That tells you how long I've been working on this stuff.
Oh yeah, no.
It's kind of a little bit crazy because when we first found Williams Cancer Center, and the more we talk, the more we find out, well, this is really new and things like that. We've been working on it for 20 years, 30 years.
Yeah. I mean, this obviously things have come along, but the big thing is that with the combinations now with immunotherapies, that's really made the difference. I mean, now we have a lot more options on immunotherapy that we didn't have, and now we have the real breakthroughs, and now we get the better understanding, and for me in this process, I mean, I basically have obtained what should be like a PhD in immunology for sure, many times over, just understanding the whole immune system and how it works and the stuff with cancer. And I think we have a much deeper understanding. We still have a lot more to understand, but I think we understand enough to make the differences now. I think we understand enough to be able to treat cancer successfully.
What's good thing about you? You didn't just find something and stop there. You're learning, continuing to learn and continue.
Always continue. I think if I ran out of stuff I would get so bored. I mean, I'm now it's like I just want to keep trying to get deeper and deeper into this and get a better understanding. I mean, really looking a lot at this connection between interleukin-1, TGF-beta. Those are really big players in this that somehow I don't know how they just got missed. Like people didn't see it, and so we're trying to sort that out now.
Maybe it didn't get missed. Maybe it got put on the shelf, right?
Well, that's what I wonder. I mean, I do wonder that. Sometimes I wonder. I look back and I'm like, gosh, did they just miss it, or did they know it and they pushed it away? I mean, it's like, but I try to figure out who benefited. I mean, I don't know. But it's strange. It's strange. I kind of look back at some of the things on it that, but the thing is that they limited things and compartmentalized them so much that made it difficult for anybody to see. I mean, what do? They look at a substance like TGF-beta and they say, well, what does it do? And how do they determine it? They look at a cell and they give it TGF-beta and they say, well, it does this. But that's not within the organism, right? That's an isolated cell pulled outside the body, and TGF-beta will do one thing. But in the body, has many actions, right? I mean, it has actions away, it has actions locally, and it's a different deal. So you can't really pull that thing out separately and look at it by itself and say this is what it does, because that gives you the wrong impression. And that's what they did. Was they said, oh, what do these things do? Let's take a cell, let's expose the cell to it. Oh, it's doing this, and that's what it does. And that's what they assume that it does, and that's not what it does.
It's not in its actual environment.
Yeah, that's what it does to that one cell, but that's not what it does when there's a whole concert of other cells and other immune cells, and that's where the actions are taking place. You know, you can look at the action on one cell, but what's the action on all the other cells? And so, and until you look at the whole thing together, and then you can take that into animals, but the immune system of the animals are different, and the immune system of the humans are different. So this is the thing as well, and this is what we're understanding, is that we know a little bit. We're gonna understand this better, but certain patients, their immune systems are going to be different because everybody has what we call like an HLA type. So you have like certain, proteins that you express because of your genetics, and that makes your immune system different. And then also the immune system of men and women are different. You know, we actually, we are aware of this, and we actually treat the men and women a little bit differently because they're not the same. So I mean, the cytokines actually, IL-6, I would argue, might have completely the opposite effect in men versus women in certain cases. I mean, it's really strange. And again, it's also the other presence of like the other hormones and things like that. Whether women with estrogen, progesterone, and things like that, there's just different work. I mean, and women are designed to be able to carry a baby, so they need to be able to suppress that immune response in a way that men never designed to do, right? We're not designed that way. And so that's why the immune system is not the same. And then that's why in cancer treatment, if we say, hey, we're going to treat everybody the same, and that doesn't work. I mean, you need to modify. What you need is to say, look, I've got all these potential drugs, and this person, I'm going to give them that. This and that. That's what you need, and that's kind of how we do our treatments.
It's truly a kind of individualized treatment, right?
It has to be really modified, particularly for that person, and we're definitely learning more and more with that. I mean, there are certain people, and I'm trying to figure them out a little bit. I haven't quite nailed it down. There's certain, I would say, Asian descent, in some. African possibly in some, but trying to nail down on the HLAs, those patients have a heightened immune response, so they're kind of weird. They get cancer, but they don't, they seem like there's but initially you give them immunotherapy, and their immune system really jump on top of it, and you have to be careful. You cannot come on top of them with too much immunotherapy, or you will overstimulate their immune response. And so we're trying to identify those patients. They tend to almost always be female, and but that those patients, because what happens, you give them immunotherapy and they're responding, but you can't tell at first, right? You don't know, are they responding or not? And so if their cancer is advanced, you're unsure, should we keep pressing or not? And so now we're trying to identify those people and understand, okay, wait, yeah, you hit them, then you get back off. You gotta let the immune system give it a little while to do it. And so with other patients, their immune response, so your standard patient, they're gonna need to press their immune system again, right? You're gonna hit them once, and then about 3 weeks later, you're going to need to probably hit them again, and then probably 3 weeks later again. And then some people, that's going to be enough. Some people, they're going to need it a few more times, but that's a normal, average run-of-the-mill person. But there's these outliers that are completely different.
That was me. One thing I was wondering, I mean, after my first treatment, when I came back for my second one, you said that it was being a little bit sluggish. So, I guess you determined. I didn't really understand what you meant by sluggish, but just
well,
experience me.
I kind of look and see like, okay, how much is the immune system attacking? And I mean, I think clearly in your case wasn't too sluggish. I think it was fine, but it's sometimes I want to push it a little bit more. So I try to look and see, is the immune system really attacking this tumor heavily, or do we need to kind of boost it? And I adjust the immunotherapies based on that. So well, I look like in a case like yours, I say, gosh, okay, it means it's kind of seeing it, but we're going to need to press it. We're going to need to use certain agents that push that type of response. So we dial. So again, it's like, you have the mix of medications and you dial them up and down. And you say, this one, we're gonna up this one, and maybe these others, okay, we'll kind of keep them. And that's how you do it.
I just have to ask, how do you know how my immune system was responding between the first and second treatment?
You can look at the scan. So there's this concept, what we call like radiomics, where so you can look at the scan and you can look at the pixelations of the tumors, and you can see what's going on. So it's not just like, okay, there's a tumor. So what do most normal people do? They look at it and say, there's a tumor, it's like 7 centimeters or whatever it is, and that's it, right? They don't say anything else. But you can actually look at the internal structure. And when you start looking at the internal structure, you'll see the differences. You'll see, oh, this part of the tumors looks like it's responding. It looks like there's immune cells infiltrating into it. This one is not. This one's actually in the tumor. You'll see this differences in the tumor based on, well, it's on the imaging, it's like a grayscale, right? So these, most of the images are grayscale. And so you look at it, and depends on your technique. Are you looking at it with CT? Are you looking at it with MRI? Are you looking at it with ultrasound? Those are your typical ways to look at it. And so that's part of this new futuristic AI system, is to develop where it will look at the tumor and will tell you what's going on, because this is how we also plan our second treatment, right? So when we look at treatment and say, this area looks like it's responding, this area looks like it's resistant. So we're going to target the resistant area, right? Because then we're going to push that. We don't need to keep pushing the responding area. We need to hit the resistant area. That's incredible.
The information you guys carry in your heads to be able to do that. That's just
it is amazing, and nobody else sees it that way. They see it just as like black and white. They don't see that type of thing, and so it's really I don't know. We're trying to get it that way, and like when I do these, I mean, I see it that way. And like when I'm working with like Dr. Vargas and other doctors, Dr. Sanchez, I just say, hey, look, do you see that? Do you see this? Like, it's not all the same. It's different, and after a while, your eyes get kind of trained to it. Now, but we think in the future, the computer systems are able to do it, right? The computer can analyze it and can tell you these type of things, and then we'll figure it out. And it'll be better.
But it's got to have the data that's in your guys' minds to be able to do that.
Well, it'll need it'll need the data, need to see the stuff, and but it's gonna start seeing it. But you can sort of start picking it out and see. I mean, it's obviously it's not perfect, but it's a better guidance. I mean, we're not just like going in there and say, let's just hit anywhere in the tumor. I think people might think that, right? They're just like, oh, just hit anywhere in the tumor. No, that's not how it is. We're specifically looking and saying, what are the areas? And this has been an analysis of cancers. So for example, one of the things that we know is that areas of cancer that have what we call hypoxia, so low oxygen concentration, those are areas of resistance. Those are areas of immune suppression, and they may not be the whole tumor. Now, if we can do a PET scan that will label the hypoxic regions of the cancer. We did this. We started doing this initially. We did a few scans, and so let me tell you my process when I went through this. Right. So my thought was that, where's the hypoxia going to be? You would think it should be in the center of the tumor, right? But that should be the least oxygenated, right? The vessels should be coming in around. The center of the tumor should be the part that has the least, and that would be the area of potential resistance. Turned out that was not the case. Yeah, hypoxia actually was higher on a lot of the edges of the tumor. That's completely backwards to what you would think. How would it be less oxygen in the edges and not in the center, that doesn't even make sense. So it's completely, but what we were seeing. So then we started realizing that the action, and so if you want to just generalize, the action of the tumor is on the edges, right? So that's where you really want to, when you want to ablate, you want to ablate close to an edge. You don't want to ablate in normal tissue, but you want to ablate to an edge generally, if you don't know, right? If you don't have other imaging to tell you, but you could have other imaging to guide you and maybe make it more precise, and maybe it's not always the edge, but it could be.
So would that be why they had that concern on the edge of my tumor, because they were?
Well, I think that edge on yours is inflammatory. Do we see this? These are immune cells that are hanging out there.
Yeah, you guys see it every day, and that's
yeah.
That's why I understand. They even the radiologists that have said that they basically just think I had an ablation done, nothing.
Yeah, they don't understand it, right? It's not something to see. But it's the things that we don't get a ton of hepatocellular carcinomas. Obviously, it's not as common of disease in at least in the Western world. But it certainly happens. But then the treatment options for patients are terrible, right? It's like they have no great options for these people. They look at liver transplants, right? Look at like stuff like that. Like terrible options. And this is a disease that responds very well. I went to Asia and I treated several HCCs there, and we just knocked it out of the park, right? We just basically cured everybody that we treated. We treated multiple patients over several days and knocking them out one, 2 shots. Completely, and then that was it. And unfortunately, COVID hit, and then it kind of kept us away from going back over and doing more. But this type of cancer is clearly one that this should be the treatment for sure. But others, whether it's colorectal, pancreatic, breast, lung, any solid cancer, we can do similar types of things just with modifications.
Well, I guess. What's your longest, living HCC patient that you're aware of? I'm just.
That's a good question. So I have some probably from maybe, because the earliest ones I've probably treated with this technique are maybe 2018. So probably 6 years. Yeah. I have other patients. I have several ones. Let's see, our early ones. I have a lot of patients that were treated 2014 that were all stage 4 cancer, still alive. Still we're still in contact with all the time.
That's awesome.
It's surprising. I think Angie told me this person contacted us. It's been so long that we treated that person. Can't believe they're still doing fine. Usually they're calling about other medical questions and things like that. But we have a group, particularly 14. So my furthest going back, since 2010 or 2011 is a stage 4 breast cancer that we treated with mainly cryoablation alone, and we got a curative response. She was metastatic, and that patient's the longest, I think, going back. Then as the immunotherapies really kind of came into play, 2014, we have a lot of those patients.
It's still new technology. I understand that. So, the 20 or 30 year history isn't there. I just want to make sure I'm around when you get that Nobel Peace Prize, so I can come.
Hopefully they
medical
give that to me. I think I will show many things that would deserve the Nobel Prize. So we'll see what happens.
Oh, for sure. It's incredible.
Well, good talking with you. And we're just going to keep following your case. Obviously there's zero need to do anything aggressive. We're just, everything looks great. We're just going to watch and we'll just mainly, I would just make sure that we got you tuned up supplement wise, off-label drug wise, so that you're getting the stuff you need to not have to run into more cancer in the future.
No, that's terrific. I really appreciate everything.
Sure, yeah. No
Immensely.
problem.
You have no idea, actually. You probably do, but not really.
This is I tell you, it's a dream come true. I mean, when I was younger, my grandmother died of breast cancer. I dreamed of being able to cure cancer. And I felt like I could do it. I mean, I felt like when I was younger. I mean, I was driven. I mean, and early in college, I was really trying to do it. And I thought that I could. But then I knew in the back of my head, it's like, but it's very unlikely, right? I mean, it's like thought I could do it, but the chances would be like winning the lottery or less, and to actually be in the position to be the person that's going to do it, which I think we have, then that is something I really couldn't believe. I mean, I guess it's a dream come true, and I think it's way better than I ever could have even imagined. And so I just right now it's the process of trying to get it out to the people. I mean, it's one thing to make the discovery and to do it, but now we got to get it out to the people. You would think it would be simple. It's not so simple.
Oh, I'm sure your grandma's smiling down on you, right?
I'm sure she is. Gosh, yeah. I mean, I look back at so many things. I look back at the old data, and I keep thinking, I see stuff like, that was discovered before she died. I was like, 'cause if they had known this, we could have saved her. I mean, it's really, disappointing. I mean, so many people died, and even like, obviously my experience, I've treated tons and tons of patients who didn't make it, right? We did lots of stuff. We were going in the right direction, but we were not made it in the full direction, and unfortunately we kind of, well, I mean, we were learning things, and so obviously, there were a lot of people that now, gosh, I mean, it's like we could have saved, but we didn't know.
Yeah, well, it's progress. I'm just glad my timing. It's all about timing, and I'm glad.
Timing, definitely, yeah.
Yours.
Timing is hugely important. I mean, you getting cancer now, a whole lot different than even just a few years ago. I mean, a few years ago would have been much more difficult. I mean, I think now we're really on it. A year ago we were really good, but I think we're way better now. I mean, I think we made a huge leap even in the last year.
That's incredible.
Now, Dr. Williams, I have a question for you. So, I think a big thing about cancer, and the most important thing is, preventative, right? What can you do to prevent cancer in the first place? So, as myself, young kids, a 1-year-old, a 4-year-old, we're both early 30s. What would you kind of recommend, that we do? Eat healthy, we exercise.
Yeah, in the supplementation stuff, like that we have your dad on, like it's like things like the sodium butyrate. I mean, again, you don't have to do this every day. I mean, a young person could do it here and there. Could do it once every week, once every 2 weeks. But I mean, so sodium butyrate, forskolin, those are certainly helpful. I mean, obviously there's like other supplementation that's decent as well. But like berberine is another one that's pretty good. For I think that again, occasionally, right? Because you just want to knock down something. The idea is that what happens is your immune system starts getting suppressed, and these things actually will help it be stronger to recognize cancer. So that's where but again, it's like you don't need a ton of it. You just need it here and there, and then clearly protecting the gut microbiome. So things like the camu occasionally, trying to avoid things that might kill the gut microbiome, like artificial sweeteners, or some natural sweeteners that are plant-based that could kill the gut microbiome as well. That the stuff like that you might want to avoid. That's helpful, and then the other thing
like that, don't really use those.
What's that?
Not really. Like things like processed meats, I know are terrible.
Yeah. So any stuff that's has like things that obviously is going to kill a lot of bacteria. So I mean, these things are designed to like keep bacteria from growing on the food, but they kill the bacteria in your intestines, right? So that type of stuff you want to avoid. And then there's been some evidence of mild supplementation with selenium, particularly women for breast cancer, but and then vitamin D being really important as well.
Yeah, I got probably one in my vitamin D, not in the summer, But in the winter, when our days are quite short,
Yeah.
we don't get sunshine. I'm not outside as much. I think especially supplementing, in the winter.
Yeah.
But in the summer, I'm outside all the time and hiking, stuff like that. So
I think again, all these supplementation stuff is like stuff that you should take here and there, right? Maybe not every day. I mean, you just have a bunch of the bottles around, and you say, today I'm going to take these 2 or 3. Tomorrow I'm going to take these 2 or 3. And you don't have to take them all the time, but just get a little bit. I mean, your body needs some, but it doesn't need a ton. And most of the supplementation is actually way too excessive. So, it's giving you 500 milligrams. You only need 50 milligrams, right? So, I mean, you're flooding it. I actually had a meeting with life extensions people last night, and I was telling them, like, I was going to try to help them design a supplement formula that would be better, that would have lower amounts of many things that people should take, and that would be better. So hopefully we could develop something that will be easier for people that could take daily.
Yeah, it'd be nice if you could have, something almost like a multivitamin, right? Where it's
Exactly.
all in there. It's all in there. You take it once a day or once every 3 days or whatever it is, right?
Yeah. I think that's what we're going to try to do, because that's what you need. I mean, again, it's like the supplement stuff is just way too much. I mean, so if we could make a formulation that has a lot but a lower amount, and that's what we're going to try to do. So yeah, well, hopefully we can work that out. We did have the meeting with the Life Extension Company, and they have good supplements. And so, I talked to them. I was like, I really would like to work with them about developing, something that would be, very useful for people, it's like basic cancer prevention.
All right, well, thanks for the advice.
Yeah, no problem. Well, good talking to you guys.
Well, whatever you need, please just let us know. Send Angie the list of supplements so we can review it. And when you have new imaging, please let us know so we can review also. As Dr. Williams mentioned, it's not always the same that a person that is not trained to read those studies after the treatment do it, because sometimes they just only a big ball, a big mass, and that really do not mean cancer necessarily. So please share us your images so we can take a look also.
Absolutely. Definitely what you guys say and recommend, especially understanding the treatment, goes far beyond what the radiologists and stuff tell me here. It's what you guys say is number one to me.